Good morning, all. Today I'll be dealing with anti-cancer drugs. Like all other antimicrobial drugs, these are the special class of drugs. Here, in antimicrobial drugs, you learn that the drugs were given for a short course regimen, like 3 days, 5 days, 7 days, like that. In the later part of the antimicrobials, you learn that this anti-tubercular drug, anti-leprosy drug, these drugs were given for 6 months, 8 months. Then anti-leprosy drug, the regimen was for 24 months. So here, the anti-cancer drugs are given relatively longer than the anti-leprosy drugs. Here, the dosage and the regimen, they will be there for like 2 years, 3 years, and sometimes lifelong regimens are available. So here we have a different class of drugs which are relatively more toxic, more mutagenic, and these are the drugs which can cause myelosuppression, and they themselves can cause cancers. So with this idea, we'll move to what is this, what are these anti-cancer drugs. So on the first slide, what you are seeing is about it just appears like a small lesion, but it is a melanoma, which is caused due to the cancer of the melanin producing cells. So coming to the understanding of this, what is cancer? Cancer is a malignant neoplasm, is a class of disease in which a group of cells display uncontrolled growth, invasion, and sometimes metastasis. Many times we don't know the disease, but you might not come across the disease, but this disease will be identified by the lymph node enlargement around the neck and all. So that will be a later stage, and that lymph node metastasis is the later part of later stage of the disease, where the treatment regimen may not be helpful. So cancer affects people at all ages, with the risk for most type increasing with age. Then we have this carcinoma. What are the different types of cancers? Like cancers of epithelial cells, cancers of different muscle tissues and all. So carcinoma of is epithelial involvement of epithelial cells, breast, prostate, colon, lung cancers. All these are included under carcinoma. Sarcoma means muscle tissue and connective tissue cancers. Then we have this lymphoma and leukemia, which is the cancer of the hematopoietic cells. Then germ cell cancers, we have this germ cells in the testes and the ovaries. Then blastomas, which are related to the embryonic tissues. So we have this different types of anti-cancer drugs. The first group of anti-cancer drugs are alkylating agents. So among the anti-cancer drugs, the major classification we have here is the cell cycle specific and cell cycle non-specific anti-cancer drugs. So what is the difference between cell cycle specific and cell cycle non-specific? Cell cycle non-specific can kill the cancerous cells in any stage, whereas this cell cycle specific, they are less harmful, and they act at specific phase of the cell. What is this specific phase? That is starting with the prophase, anaphase, metaphase, like that. So what are the different stages of the cells they will be acting? So alkylating agents, we have this nitrogen mustates, that is cyclophosphamide, chlorambucil. Alkyl sulfonates, we have busulfan. Nitrosoureas, we have carmustine, lomustine. Ethylene amines, we have this thiotepa. Triazines, we have dacarbazine. Antimetabolites, we have the folate antagonist, methotrexate. Purine analogs, we have thiazolidine, mercaptopurine, and fludarabine. Pyrimidine analogs, we have cytarabine and fluorouracil. Okay, so this 5-fluorouracil is also used as an antifungal drug. Here also it finds a position. So anti-cancer antibiotics, which are acting on the topoisomerase 2. We are having here anthracyclines, doxorubicin, hydrochloride, daunorubicin, bleomycin sulfate, mitomycin, dactynomycin, glycomycin, all these cells. Then we have this plant-derived products, vinca alkalides, vincristine, and vinblastine. Epipodophyllatoxins, we have etoposide, teniposide. Then taxanes, we have paclitaxin and docetaxin. So these platinum derivatives are the more dangerous ones. We will be learning about them. Then we have the hormonal anti-cancer agents. We have for glucocorticoids, we have prednisolone. Estrogen anti-estrogen, we have tamoxifen, estradiol. Androgen anti-androgen, we have glutamide. Progesterone, we have hydroxyprogesterone acetate. Luteinizing hormone, LHRH releasing hormone antagonist, we have this buserelin, leuprolide. Immunomodulators, we have levodopa. Interferons, among interferons, we have interferon alpha 2A and 2B. Interleukins, and we have aldesleukin. Along other than this, we have this aromatase inhibitor, that is anastrozole, letrozole, all those group of drugs. Then targeted anti-cancer drugs, we have BCR-ABL tyrosine kinase inhibitor, imatinib, dasatinib, nilotinib. EGF receptor inhibitors, we have geftinib, erlotinib, cetuximab, lapatinib. Angiogenesis inhibitors, we have bevacizumab, sunitinib. Proteasome inhibitor, we have bortezomib. CD20 inhibitor, we have rituximab. Miscellaneous anti-cancer drugs, we have hydroxyurea, procarbazine, mitotane, cisplatin, carboplatin, mitoxantrone. Cellular growth factors, we have filgrastim, sulfonylurea, enzyme L-asparginase. So all these are the miscellaneous type of anti-cancer agents. So here is a diagram showing you cell cycle specific anti-cancer drugs. Cell cycle specific anti-cancer drugs. Here we have this G2 phase acting drugs, that is epipodophyllatoxin, etoposide, teniposide. Taxanes, we have docetaxel, paclitaxel. Then we have this metaphase acting, that is vincristine, vinblastine, vinorelbine, all these agents. Then we have topoisomerase inhibitors or DNA kinase inhibitors, that is topotecan, irinotecan. Then we have the S phase acting. So here in S phase acting, we have this antimetabolites, that is folate antagonist, methotrexate. Purine analogs, we have cladribine, fludarabine, mercaptopurine, pentostatin, theobromine. Pyrimidine analogs, we have capricitabine, cytarabine, gemcitabine, fluorouracil. This fluorouracil is known as 5-fluorouracil. Then miscellaneous, we have hydroxyurea. So we have the enzymes, that is asparginase, aspargase, all these agents. So coming to the first group of drugs, that is alkylating agents, which are cell cycle non-specific and more toxic ones. Among them, alkylating agents, we have this nitrogen mustates, that is cyclophosphamide, chloramycin, meclorethamide. Then we have alkyl sulfones, busulfan. Nitrosureas, we have palmistine, lomistine. Ethylene imines, we have thiotepa, triazine, dacarbazine. Mechanism of action here is cross-linkage, mispairing, and depurination. So the mechanism of action is cross-linkage, mispairing, and depurination. So cytotoxic agents, we have alkylation of DNA. Here is uses where we can use this are hematologic and solid cancers and used in combination therapy. Adverse effects here are direct recycling effect, nausea and vomiting after 30 to 40 minutes of injection. Mutagenicity is also seen. Nitrogen starts. We have this cyclophosphamide. So cyclophosphamide is the most commonly used anti-cancer drug. So how does it act? So most of the time they are involved in misreading of the DNA base pairs or alkylation of the N7O6 of guanine. So that is the basic step or basic method by which these anti-cancer drugs work. So this cyclophosphamide can get metabolized into uh, phosphoramidase. Then it is converted to aldophosphamide, which is broken down into phosphoramide mustard. It's a bifunctional, and we have the other metabolite, that is acrolein, which is a cytotoxic. So oral bioavailability is about 90 to 100%. IV injection, no local irritation is seen. Half-life of cyclophosphamide is about 3 to 10 hours. Then aldophosphamide is about 1.6 hours. So it is metabolized and excreted unchanged in urine. Less than 14% is excreted in urine. So nitrogen mustard cyclophosphamide, where we can use it. So active on lymphoproliferative disease, we can use it for Hodgkin's disease, chronic lymphocytic leukemia. Then significant activity against multiple myeloma, ovarian, breast cancer, and small cell carcinoma. So combination treatment is very common in anti-cancer regimens. We have this cyclophosphamide, vincristine, prednisolone regimen, MOP regimen, where methotrexate, oncovin, prednisolone, procarbazine. Okay, so this combination is tried. MOP regimen, CHOP regimen, all these are seen. Then adverse effects here are cystitis, that is inflammation of the urinary bladder. Then dysuria, fibrosis, hyponatremia, all these are seen. So the bone marrow suppression, leukopenia and thrombocytopenia is commonly seen. Nausea and vomiting are said to be rare. So acrolein can cause sterile necrotizing hemorrhagic cystitis. So they can ask you acrolein as a short answer. So we should be able to write the demerits of acrolein, and we should write that acrolein is a metabolite of cyclophosphamide, which can cause the severe type of adverse drug reaction, that is sterile necrotizing hemorrhagic cystitis. Then nitrogen mustards, we have this sulfur mustard from toxic cyclic aryl ammonium ion. So metoclopramide can be used at the dose of 0.4 milligram per kg as a single dose. So T-half is about 10 minutes after administration. So this can also be part of the MOP regimen tried for Hodgkin's lymphoma, leukemia, lymphosarcoma, all these conditions. So the adverse effect, as like with most other anti-cancer drugs, we have myelosuppression, that is the bone marrow suppression, teratogenicity, carcinogenicity. So all these are seen. Coming to the nitrosurias, we have this carmustine, lomustine, and silmustine. So the mechanism of action here is chloroethyl moiety capable of alkylating nucleic acid and routine alkylation and carbonylation of DNA. So mechanism of action is chloroethyl moiety alkylating the nucleic acids and proteins. Alkylation and carbonylation of DNA will takes place. So these agents can kill the cells in all phases of the cell cycle. So they can be non-specific, that is like they can also kill the normal growing cells within the body. So these are the demerit of the cell cycle non-specific drugs. So T-half is few minutes renally excreted. So used in the treatment of Hodgkin's disease, lung cancer. Adverse effects are in the form of bone marrow suppression, thrombocytopenia, interstitial fibrosis, all these things can be seen. So alkyl sulfonate busulfan, it is a bifunctional methyl sulfonic ester that forms interstrand cross-linkage with DNA. Busulfan is a bifunctional methane sulfonic ester that forms interstrand cross-linkage with DNA. So palliative treatment is the main condition that we are using for like chronic granulocytic leukemia. We use this busulfan the dose of 2 to 8 milligram per day. So maximum 250 milligram per course. So orally the TF is less than 5 minutes. It's treated in urine. So busulfan is tried in combination with allopurinol, which prevents the excess of uric acid production from rapid tumor lysis. So adverse effect in the form of selectively toxic to granulocyte precursors rather than lymphocytes. So selectively toxic to granulocyte precursors. So it can cause this interstitial pulmonary fibrosis, thrombocytopenia, anemia, and gynecomastia. So adverse effects, as we can summarize, the most common adverse effect of this anti-cancer drugs is myelosuppression, carcinogenicity, and teratogenicity. So here we can see all the things are mentioned. More toxic to the bone marrow, that will be myelosuppression. Then infertility it can cause, it can be mutagenic and carcinogenic. So tumor resistance can develop slowly. That is the tumor itself is not susceptible to the alkylating agents anymore. We'll be learning more about it. Coming to the anti-metabolites, so the normal mechanism of metabolism of folic acid, where they will be affecting. So the most common drug is folate antagonist methotrexate. So being the folic acid synthesis inhibitor, they can also inhibit the synthesis in the normal growing cells, and the growth of the cells can be altered in presence of the methotrexate. Sometimes this myelosuppression will be so much so severe that we will stop the drug so that the body cells can recover. So here we have this purine analogs, theobromine, mercaptopurine, procarbine, pyrimidine analogs, cytarabine, and fluorouracil. So these are structurally related to naturally occurring compounds such as vitamins, amino acids, and nucleotides. So these drugs can compete for binding sites on the enzymes, or can themselves become incorporated into DNA or the RNA and thus interfere with the cell growth and proliferation. So here, once they get falsely incorporated, the chain elongation will be prevented. So once the chain elongation is prevented, the bacterial growth or the growth of this cancerous cells will be prevented. So folic acid analog methotrexate binds strongly to the DHFR to deplete the THF and decreases one carbon transfer in purine synthesis and decreases one carbon transfer, that is intracellular, which decreases the uridine monophosphate and triphosphate. So they decreases the nucleic acid synthesis. The net effect of this methotrexate is decreasing the nucleotides formation, or nucleic acid synthesis will be affected. So then we have the clinical users. The users is acute lymphoblastic leukemia of childhood, choriocarcinoma, cancer of breast, head and neck, usefulness of the usefulness in non-Hodgkin's lymphoma. So methotrexate adverse effects, dose limiting, that is myelosuppression, leukopenia, GI toxicity, severe ulceration, bleeding, nephrotoxicity, immunosuppression, hepatotoxicity. So all this can be seen. So methotrexate adverse effects itself is a short notes for you. Myelosuppression, leukopenia, GI toxicity, diarrhea, nephrotoxicity, immunosuppression, and hepatotoxicity. So coming to the next drug, that is pyrimidine antagonist, 5-fluorouracil. So it is activated by conversion to nucleotide, inhibits the DNA synthesis, inhibition of the thymidylate synthesis, the most important mechanism of action in rapidly growing tumors. So 5-fluorouracil is incorporated into the RNA, interferes with the RNA processing. So most important mechanism for slow growing tumors. Otherwise, this 5-fluorouracil is not so powerful drug. It is used commonly as an antifungal drug. So commonly we are using it as an antifungal drug. Means the side effects related to this 5-fluorouracil will be relatively low. Only thing is it can also affect the normal cells. So clinical uses of this 5-fluorouracil, single agent, we are using it for advanced colorectal carcinoma. In combination, fluorouracil is tried with breast cancer, carcinoma of ovary, so combination is tried for breast cancer, carcinoma of ovary, stomach, and pancreas. So sequential blockade, that is methotrexate plus 5-fluorouracil, they are tried for head and neck cancers. So 5-fluorouracil, it can cause this bone marrow suppression, leukopenia, thrombocytopenia, GI toxicity, stomatitis, diarrhea. All these things can be seen. So myelosuppression, megaloblastic anemia, hepatotoxicity, these are also part of this. So coming to the purine analogs, theobromine, incorporation of a thionucleotide analog into DNA or RNA. So feedback inhibition of the purine nucleotide synthesis. Pharmacokinetics is it is slow orally acting drug. PF is about 1 day. It is used in the treatment of combination chemotherapy for AML, that is acute myelogenous leukemia. Adverse effects are in the form of myelosuppression, leukopenia, thrombocytopenia, liver toxicity. All these can be seen here. So all of you might be aware of this beautiful plant, which are actually growing in the outside our compound. So commonly found flower plant in the in India. So what are the alkaloids we are obtaining from it? We are obtaining vincristine, vinblastine, vinorelbine from this vinca alkaloids. So these are having the anti-cancer properties. So they bind to the they bind actively to the tubulin, a class of proteins that forms a mitotic spindle during the cell division. So it can cause the arrest of the cell cycle in the metaphase. These are the plant-derived products, vincristine and vinblastine. So they are highly bound to the tissues. So it is a vincristine is used for MOP regimen. Here, MOP regimen means methotrexate, oncovin, prednisolone, and procarbazine. So here, O stands for vincristine. So vinblastine, it is tried for the testicular cancer, breast, and renal cancer. Adverse effects are in the form of alopecia, neurotoxicity, myelosuppression. Will be there. So bone marrow toxicity, leukopenia, SIADH means syndrome of inappropriate secretion of antidiuretic hormone. So we have this anti-tumor antibiotics. So all interact with the DNA and the RNA, but may also interact with other cellular substituents. So the schedule depends upon less space specific in the anti-metabolites. So tissue necrosis is the only generable toxicity. So all are given intravenously except for bleomycin. So the mechanism of action of anti-tumor antibiotics is DNA topoisomerase inhibition, which is crucial to the DNA replication and translocation. So traditional explanation here is interconnection between the base pairs of DNA and inhibits the DNA-dependent RNA synthesis. So this alkylating agents can inhibit the DNA-dependent RNA synthesis. So it can generate free radicals that cause the membrane damage and DNA strand breakage. Okay, so they can generate the free radicals and cause membrane damage and DNA strand breakage. So the next anti-tumor antibiotics we have is doxorubicin or adriamycin. So which is a broad spectrum anti-cancer activity. It has broad spectrum anti-cancer activity. We have this Hodgkin's disease, non-Hodgkin's lymphoma, sarcomas, acute leukemia, breast, lung, and ovarian carcinomas in all responsive cases. So activity observed in bladder tumor and carcinomas of the prostate, thyroid, endometrium, head and neck, and other solid tumors. So the important point for this anti-tumor antibiotics is the type of adverse drug reaction. We call it as a radiation recall reaction. So what is this radiation recall reaction means? When we are not able to give some oral drugs or parenteral drugs, or the cancer is in a very late stage, we give radiation. So in once we give radiation, there will be a lot of cells killed in the body. So that's why when we are giving this radiation, the person loses hair, the person loses his charm, all these things are possible. So in the same way, anti-tumor antibiotics when given, they also mimic the similar picture. So they are more toxic agents to be in a straight line. So local toxicity, then interaction of doxorubicin and radiation in some tissues to produce enhanced reactions and are also possible. So reactions include skin in the form of ulceration, necrosis, pulmonary fibrosis, esophageal mucosa sloughing, heart and intestinal mucosa also be affected. So the three categories of toxicity, they are local toxicity, acute toxicity, and chronic toxicity. Local toxicity is like these germs are wherever the injection is given, there can be extravasation. It can cause this local toxicity, severe necrosis, all these things. Then coming to the other toxicities, hematologic leukopenia can occur within 10 days. So recovery will take another 10 days. Thrombocytopenia and anemia is less common, but can also occur. So if given too fast, they can cause the histamine release syndrome. So cardiac arrest can occur, but preceded by ECG changes. So anywhere else, if you have learned about this histamine release syndrome, so yes, when we give this opioids fast, also there also histamine release syndrome like condition can be seen. So here this histamine release can be prevented by slow administration. Then cardiomyopathy, congestive heart failure, which can be aggravated and needs the cessation of treatment. So coming to the hormonal anti-cancer agents, we have this progestins and all. So we'll be learning more about this progestins later. So we'll just learn till the anti-cancer antibiotics. Okay, so we'll finish this topic. So this hormonal anti-cancer drugs uses the basic concept. What is that basic concept? If at all the tumor is estrogen dependent, we use a estrogen antagonist. If at all the tumor is progesterone dependent, we use the progesterone antagonist. And sometimes the agonists are also used in the tumors, owing that circulating progestins can be helpful in suppressing the progestin release. Okay, so progesterone agonist and progesterone antagonist both are tried in this hormonal anti-cancer agents. The anti-progestin agents, they can be helpful directly by acting against the progestins at the site of receptors. But sometimes the agonists are also used so that we increase the circulating level of the agonist, and increasing level of circulating agonist will suppress the internal progesterone release. So progesterone agents have been used as a second-line hormonal therapy for metastatic hormone-dependent breast cancers and endometrial carcinoma. Metastatic hormone-dependent breast cancer and endometrial carcinoma previously treated by surgery or radiotherapy. So progesterone stimulate the appetite and restore the sense of well-being. So in advanced stages of cancer, HIV, they will be. So we have something called as selective estrogen receptor modifiers. They are on certain tissues they will act as an agonist, and certain tissues they will act as an antagonist. That's why we have the term selective estrogen receptor modifiers. So what is the role of this tamoxifen citrate? So it is most widely studied anti-estrogen treatment in breast cancer. So anti-estrogen treatment in breast cancer and prevents development of breast cancer in women with high risk from non-malignant breast. So here inheritance of this BCR-C1-C2 is there, means that becomes difficult to treat. So adverse effect, vasomotor symptoms, atrophy of the alignment of vagina, loss of hair, all these things can be seen. Then we have this tamoxifen, which binds actively to the estrogen receptors in conflict with the estrogen for the clinical sites, inhibits the growth of the ovarian, uterine, and breast tumors. For ovarian, uterine, and breast tumors. So here the maximum effect is up to 4 to 6 hours. Then their metabolism takes place by hydroxylation and glucuronidation. The synthetic anti-estrogen used in the treatment of the breast cancer. So adverse effects are in the form of the hot flushes, nausea, exaggeration. So then we have this selective estrogen receptor downregulator. That was a modulator. Here it is a downregulator. We call it as fulvestrant. So fulvestrant is used in the postmenopausal women with a hormone receptor positive metastatic breast cancer. Then we have this aromatase inhibitor, anastrozole, letrozole, which is a non-steroidal immunogens, are used as a part of the standard care of treatment for early stage and advanced breast cancer. So it is used for cancer in postmenopausal women also. Aromatase inhibitor. Then we have this gonadotropin analogs and gonadotropin antagonists. So gonadotropin analogs means those agents like FSH and LH, which stimulate the growth of the gonads. It may be males testes, in females it is the ovum, ovaries, like that. So how we can help this people means when we are using the agonist, for example, gonadotropin release hormone agonist, neoprolide, gossarin, these actually inhibit the feedback inhibition or the release of the hormone. Okay, thereby depending on further exposure to hormones. The GnRH agonists are neoprolide, gossarin, tryptophan, histamine, glycerin. So GnRH agonist will deplete the testicular androgen, while the anti-androgen component competes at the receptor for subdued androgenism. So GnRH antagonist, we have the sabarilics, goserilics, all those things. So they rapidly achieve the medical castration. Adverse effects here are in the form of local irritation and anaphylaxis. So the anti-androgens, we have the ciproterol, acetate, and megestrol. So these anti-androgens bind to the androgen receptors and competitively inhibit the binding of the testosterone to the dihydrotestosterone. Then we have this non-steroidal anti-androgens, that is flutamide and glycosamine. So here flutamide, glycosamine, it will be short answer for you. So we'll continue in the next class. So far, if you have any doubts, you can ask me. So from the enzyme type of anti-cancer drugs, we will be learning in the next class. So here, coming to this flutamide and bicaltamide. So it can be used for ovarian and endometrial cancers related to the hormone-dependent cancers. There we can go for this. So here the classification is very important. You should remember the classification. So what are the different types of anti-cancer agents? How we are classifying? What are the cell cycle specific? What are the non-cell cycle specific? This diagram will be important for you, which will fetch you the marks. So if you can go home and make a chart in capital letters, so that at least in the final exam they may ask you name 4 anti-metabolites. Like that, if they ask question, it will be easy for you to answer. So cell cycle specific anti-cancer agents, that can be main question. Cell cycle non-specific anti-cancer agents. So those agents which are not here in this slide will be the cell cycle non-specific. So those were the alkylating agents majorly. So this idea, I think you'll be able to understand better. So toxicity inhibitors are also seen in antibiotics. Okay, antimicrobial antibiotics, where which group of drugs are called as DNA carriers inhibitors or toxicity inhibitors? They are fluoroquinolones. Okay, so fluoroquinolones, they are acting on both fluoroquinolones. They were commonly used antibiotics. So fluoroquinolones are used as a second line anti-tubercular drugs also. So here in this case, here we are having the DNA carriers inhibitors, that is the topoisomerase 1 inhibitor, Adriamycin and topotecan. So thank you all.